Good morning, everyone. I have got the postpartum hemorrhage, which is a green top guideline, a very important guideline for revision of your MRCOG exams, summarized for you. I hope you'll find this summary useful, and if you do, then please do give this video a thumbs up and subscribe to my channel if you haven't already. So BPH minor is between 500 and 1000 mils, and major BPH is defined as anything over a liter or 1000 mils. The major BPH is further divided into moderate, which is basically anything over a liter to 2 liters, and severe, which is anything over 2 liters or 2000 mils. Primary PPH is bleeding over 500 mils or more within 24 hours of giving birth. Secondary PPH is bleeding, significant amount of bleeding between 24 hours and 12 weeks postnatal. If there's any risk factors for PPH, then delivery should happen in a hospital setting with blood bank on site. Most common cause of PPH is actually uterine agony. Risk factors and associated levels of risk for PPH. So multiple pregnancy is a risk factor, previous PPH, preeclampsia, fetal macrosomia, failure to progress in second stage, prolonged third stage of labor, retained placenta, placenta accreta, episiotomy, perineal lacerations, and general anesthesia. Minimizing risk. So uterine massage has not been shown to be of any benefit for prophylaxis of BPH. Prophylactic uterotonics reduce the risk of BPH. So that's oxytocin 10 units IM given for prophylaxis for a vaginal delivery, and oxytocin 5 units IV given for cesarean section. Symptometrin, which is basically ergometrin and oxytocin combined, should be given in patients who have no history of hypertension. It also reduces the risk of minor PPH, which is PPH of 500 to 1000 mils. IV tranexamic acid, a dose of 0.5 to 1 grams, can also be given at cesarean section to reduce blood loss. Carboprost is another drug that we use to manage PPH. It's basically 15-methyl prostaglandin F2 alpha analog. The recommended dose is 250 micrograms given intramuscularly, and this can be repeated every 15 minutes to a total dose of 2 milligrams, which is basically 8 doses. Misoprostol is E1 prostaglandin analog and is usually given at a dose of 800 micrograms. So clinical signs of a patient who's losing blood. So patients lost over 1000 mils, they will become tachycardic, tachypneic. They will have a recordable fall in systolic blood pressure if the blood loss has been between 1000 and 1500 mils. It might be a very small fall in systolic blood pressure, but it can be picked up. A systolic blood pressure of less than 80 and with worsening tachycardia, tachypnea, and altered mental state means there has been a blood loss of more than 1500 mils. So as a clinician, it's very important to keep an eye on these signs, because it's very easy to get task focused and just look at controlling the bleeding, but and to lose that helicopter view, and you may be losing the patient in front of you, because for many of you, as you know, when you're managing a PPH, you basically stood right over the bleeding area. So your multidisciplinary team, like your midwife, your anaesthetist, may not actually appreciate how much blood you're losing unless you vocalize and communicate with your team. So the MDT approach should be always taken to manage PPHs, which means to involve an experienced midwife in addition to involving a midwife in charge, an obstetric middle grade doctor, anaesthetist, middle grade, on-call clinical hematologist, porters for delivery of specimens. So normally, when there is a PPH on labor ward, the emergency buzzer would be pulled, and the MDT team, like the theatre staff, the anaesthetist, the obstetric registrar, the midwife coordinator, will all be alerted so they can head straight to the room to help everyone out. So measures for minor PPH. So you would want to get IV access, ideally one 14-gauge cannula, urgent bloods for group and save, full blood count, coagulation screen, including fibrinogen levels, check heart rate, respiratory rate, blood pressure recording every 15 minutes, and commence warmed crystalloid infusion as soon as possible. So for major PPH, check airway, breathing, so that's your A, B. C is to check circulation and position the patient flat. Consider transfusion if clinically indicated. Until blood is available, 3.5 liters of warmed, clear fluids should be given. Initially, 2 liters of warmed isotonic crystalloids, and then further fluids with isotonic crystalloid or colloid should be given until blood is available. So fluid therapy and blood product transfusion, and this is again from the green top guideline. So crystalloids up to 2 liters of isotonic crystalloid, colloids up to 1.5 liters of colloid until blood arrives. Blood, if immediate transfusion is indicated, give emergency group O, rhesus D negative, K negative red cell units. Switch to group specific red cells as soon as possible. Fresh frozen plasma, FFP. Administration of FFP should be guided by hemostatic testing and whether hemorrhage is continuing. If prothrombin time or APTT, which is activated partial thromboplastin time, are prolonged and hemorrhage is ongoing, administer 12 to 15 millimils of per kilogram of FFP. If hemorrhage continues after 4 units of red cells and hemostatic tests are unavailable, administer 4 units of FFP. For platelets, administer 1 pool of platelets if hemorrhage is ongoing and platelet count is less than 75 into 10 to the power of 9 per liter. Cryoprecipitate, administer 2 pools of cryoprecipitate if hemorrhage is ongoing and fibrinogen levels are less than 2 grams per liter. So how do you manage a PPH? So you palpate the uterus, the fundus, and rub the fundus to encourage our contraction of the uterus. You empty the bladder, normally with a Foley's catheter, and leave the catheter in. Oxytocin 5 units by IV injection should be given. Ergometrin 0.5 milligrams by slow IV or IM route. It's contraindicated in patients who've got hypertension. Oxytocin infusion, 40 units and 500 ml of crystalloids at 1 to 5 mils per hour should be given unless the patient needs to be fluid is fluid restricted in any way. Carboprost is 0.25 milligrams by IM injection given at 15-minute intervals and a maximum of 8 doses. Avoided or used in caution with in patients who have asthma. Misoprostol, we said 800 micrograms sublingually can also be administered. Therapeutic goals of management of massive blood loss. So you want to manage and keep the HB above 80, platelets above 50, prothrombin time less than 1.5 times normal, APTT less than 1.5 times normal, and fibrinogen greater than 2 grams per liter. So for the blood, you want to, if there's no group specific blood available, then it should be rhesus, it should be group O, rhesus D negative and K negative blood unit that should be given until the patient's specific group is available. So, intraoperative cell salvage, when that is used, for example, a type of cesarean section, then it has a relative reduction of blood transfusion of 38% and an absolute risk reduction of 21%. So, transfusion of FFP, as we said, if there's ongoing bleeding after 4 units of RBC, then FFP at dose of 12 to 15 mils per kilogram should be given until hemostatic tests are available. Fibrinogen levels should be maintained above 2 grams per liter if there is ongoing PPH. Cryoprecipitate is normally what you give to replace fibrinogen levels. A Bakri balloon, so we're now moving on to the surgical ways of managing PPH. So a Bakri balloon is essentially a large balloon that's inserted into the uterine cavity and is inflated depending on your uterine atony, and it's then left in for at least 4 to 6 hours to help the uterus to contract well and to minimize bleeding, and is successful in avoiding hysterectomy in 75% of cases. So it's quite an effective tool to manage PPH. The Blynch suture has an overall failure rate leading to hysterectomy of 25%. So it might be important to ligate vessels to help um, control bleeding. So stepwise uterine devascularization should be considered, which involves successive ligation of one uterine artery, both uterine arteries, low uterine arteries, one ovarian artery, and both ovarian arteries in the management of PPH. When internal iliac artery ligation needs to be done, a senior gynecologist or a vascular surgeon should be involved, as there is risk of there's risk of ureteric injury. A subtotal hysterectomy may be considered for if a hysterectomy is needed for a PPH, just to be able to do the procedure quickly, so the blood loss can be managed. Secondary PPH, the most common causes can be endometriosis and retained placental tissue, RPOC. So a vaginal microbiology swab should be sent. The patient can be started on antibiotics, and a pelvic ultrasound scan should be requested to rule out any retained products of conception. So all staff should receive training in managing PPH. They should have team rehearsals in management of scenarios of obstetric emergency, which include managing postpartum hemorrhage. Document clearly what happened and how it was managed. In some trusts, they have performers where you can just tick off which PPH drug was given at what time, and also who was involved in the care of the patient, and also debrief the patient and inform the patient of what happened, including their partner, at a convenient time. So this is just a flow chart, again taken from the Green Top guideline, which just goes through everything that we've already discussed. But I'll give you a few minutes just so you can go over this as well. So there is major obstetric hemorrhage and the blood loss greater than 8,000 mils. Call for help. Senior midwife, obstetrician, anaesthetist, alert the hematologist, alert blood transfusion laboratory, alert consultant obstetrician on call. Airway, breathing, circulation should be checked. Oxygen mask 15 liters. Fluid balance, we talked about. Blood transfusion should be considered. Blood products like FFP, platelets, cryoprecipitate should all be considered. Keep patient warm. Okay, then medical management. We've already discussed the drugs like oxytocin, ergometrin, oxytocin infusion, carboprost, misoprostol. In terms of securing IV access, you want two 14-gauge cannulas. You want blood sent for FBC coagulation. User needs LFTs, cross-match 4 units, FFP and platelets, and cryoprecipitate, ECG, oximeter, Foley's catheter, HB bedside testing, so like a test for a quick hemoglobin level. Blood products should be available. Consider central and arterial line. Commence um, um, record chart, weigh all the swabs and estimate blood loss. Theta is the uterus contracted, examine under anesthesia, has any clotting abnormality been corrected. Intrauterine balloon tamponade, brace suture, consider interventional radiology. Surgery, stepwise uterine devascularization, bilateral internal iliac ligation, hysterectomy, um, with a second experienced clinician, uterine artery embolization, and the patient may need to be cared for in a high dependency unit or intensive care unit after all the blood loss that they've had. Well, that's it. That's a summary of the PPH guideline. It's quite a long guideline to read, so I thought I'll all summarize the important points for you, hopefully for your upcoming MRCOG exams, and I wish you all the best.